To it. So hello and welcome everyone to the Real World Healthcare Security webinar. I'm Courtney Kelly and I'll be your moderator today. We're super glad to have you with us all today and explore the ins and outs of cybersecurity and how healthcare actually operates rather than how it often looks on paper. Before we begin, just a few housekeeping notes. So today's session will run for approximately 45 minutes. We'll leave time for Q&A at the end, so please feel free to submit your questions in the Q&A box anytime during the discussion. The webinar is also going to be recorded, so we'll share the recording afterward in case you'd like to revisit it or send it to any colleagues. And so today I'm joined by two experts that are going to help us navigate the realities of healthcare security. Richard Staines is with us today. Richard, could you briefly introduce yourself?
Yeah, absolutely. So I'm Richard Stainings. I've spent the last 30 years in healthcare cybersecurity, helping governments around the world and healthcare providers to deal with the privacy, security, compliance needs of protecting their patients and their assets. I currently lead cybersecurity strategy for medical device security company Cylera. I'm also a professor of cybersecurity at the University of Denver, and I get to sit on a number of government committees of inquiries as an expert witness and various other things right the way around the world. So my reach is fairly global, although I'm US based.
Awesome. Thank you so much for that, Richard. And also joining us today from Picus is Can Yuceel. Can, could you also introduce yourself as well?
Hey everyone, my name is Can Yuceel. I am with Picus Security, and I am the security research lead of the team, and I have 10 years of experience in the field of offensive security and compliance. Happy to be here.
Thank you very much. Okay, so going forward, as many of you know, healthcare environments don't allow for easy trade-offs. You can't pause patient care to apply a patch or take a medical device offline because if it failed a scan. At the same time, organizations are expected to remain compliant, manage thousands of vulnerabilities, and defend against attackers who don't operate on audit cycles. That tension between compliance and real-world readiness is what we'll be really unpacking and diving into today. So Richard, from your perspective, why does being compliant so often fail to translate into being ready for real attacks?
Yeah, so I think you raise a very important point there, Courtney, because organizations, government, right the way to government ministers, and senior executives of healthcare entities around the world have been under the illusion that the fact that they may meet their local national healthcare regulations, they may be HIPAA compliant in the case of the US, they may be JCO compliant or Joint Commission, they may be compliant with NIS2 in Europe or other regulations, including GDPR. But that doesn't necessarily mean to say that they are secure, right? These regulations that they're adhering towards compliance were written many years ago. HIPAA was written in 1996, right? At a time when those of us who were old enough to remember were probably using a dial-up modem to connect to the internet, right? And Windows 95, which was new on our PCs at the time. I don't think anyone here would do their internet banking on a Windows 95 machine. Yet we keep a lot of our hospitals running on similar age equipment, right? Particularly medical devices, which is an area that I focused on, right? So we're faced with some huge challenges here in perception and also managing a risk and differentiating risk from cybersecurity compliance.
Thank you for that, Richard. So Richard mentioned that most breach healthcare organizations were compliant at the time of attack. Can you explain the difference between a compliant and a robust security posture?
Compliance gives us a great framework to follow. However, it does not mean that we are secure right at the gate, because compliance gives us the puzzle work that says that you should do this, you should do that, and you will be compliant with the regulation. However, real-world attackers does not care about your compliance requirements, and they do not care about how secure you are in terms of compliance. So you need to test your security devices and the security posture at all times to be secure against certain cyber attacks. Because annual assessments are required by compliance, and we do penetration testings once a year. However, how about 3 months from now, 6 months from now, will you be still compliant and still secure in terms of cybersecurity? So we need to run multiple test runs so we can say that we are secure at this moment and still secure against the cyber attacks that may be coming in our way. That's why the difference between being compliant and having a robust cybersecurity posture is having controls and also knowing that they are actually working at the time of attack.
Thank you so much, Can. So if compliance alone doesn't guarantee readiness, then the next challenge is what healthcare teams do when fixing the issue isn't really actually an option. Many of the most critical systems in healthcare can't be patched, upgraded, or taken offline without real operational risk. So let's shift the conversation a little bit to how organizations can protect these environments when traditional remediation simply isn't possible. So Richard, can you share the operational reality of healthcare systems today?
Yeah, I think there's an opportunity here to talk about a risk-based approach to healthcare versus a checkbox-based approach, right? The compliance that Can was talking about just now, right? If you go through a checkbox and you check the boxes, it doesn't necessarily say that there's been any neurons connecting over what a perpetrator might do in order to break in or cause damage to a patient care environment like a hospital or a clinic or whatever. I think there's a second point here, which really is around resiliency, the need for better resiliency and the need for better protection of healthcare systems. They are part of critical infrastructure in just about every country in the world. And we need to make sure that they are protected a lot better. And then secondly, I think we need to look, using that risk-based approach, at devices that may be high risk because they cannot be patched. And I talk here specifically about medical devices because 75% of the connected endpoints on a hospital network are not managed by IT. They're managed by facilities, they're managed by biomedical teams, they're managed by physical security teams in the case of proximity door locks and CCTV. They may include things like remote management of HVAC systems and elevators, which are absolutely critical for hospital workflows and for pandemic disease control. If we hadn't been able to manage positive airflows, all of our nurses and doctors would have become infected with COVID. As patients poured into the hospital. Similarly, if we can't keep an operating room clean with positive air pressure, then that invites pathogens into the open wounds of patients, which then causes surgical complications, right the way up to incidences of morbidity and mortality. So there's a lot of systems that need to work together in order to deliver healthcare. And it's not just the doctors and the nurses. But it's also a lot of these medical devices. Now, a lot of the medical devices in a hospital environment are up to 25 years old, right? 25 years ago, as I talked about earlier, we were running Windows 95. It's considered hopelessly insecure today by today's security standards. So we need to look at alternatives if patches are not available for these legacy systems. And I think that comes down to compensating security controls, things like micro-segmentation of at-risk devices and networks, adopting zero trust framework as to who has access to these systems, and also object level access as to what other systems should have access to data and critical systems that may be at risk because they cannot be patched.
You're so right, Richard. Thank you so much for that explanation. Patching is a great option, but it's not the only option. Can, are you able to explain how to protect the device without actually patching the system itself?
Like Richard said, many healthcare organizations do not have the newest and the latest stuff. Unlike manufacturing or financial organization, they can often pay up for the newer stuff and they can renew their devices. However, it's not an option for most of the healthcare organizations. Patching is essential, but mostly it's not always feasible, especially in the healthcare setting, where devices are often have operational dependencies that cannot be interrupted. In such cases, we can still protect devices by validating segmentation, like putting firewalls between the attacker and the healthcare organization's environment, and we also need to do microsegmentations within that organization. So once an adversary can breach the first firewall, they cannot breach the next one, and they can take control of the entire infrastructure. So we need to implement segmentation, implement firewall rules, and other compensating controls. For example, ensuring that sensitive systems are isolated with secure segments that of the network, and they can prevent attacker from moving laterally from one system to other systems. These compensating controls can act as a layer of defense without needing to touch the device itself. As Richard said, most of the devices are an end of life, so they are not available patches for these devices. So without updating those outdated systems, we can still patient, and also we can run these outdated devices and deliver patient care.
Thank you so much,
you raised
Can. Oh, go ahead, Richard.
I was just going to chime in there, Courtney, if I may. You raise a good point there, Can. Some of these legacy systems are not just old and very, very expensive to replace, but they may be on a hospital amortization schedule that is 20 or 25 years old. And the fact that the vendor has gone out of business or no longer is providing patch support to a system is irrelevant to hospital finances and the CFO, right? They have $25 million, $35 million asset that is depreciated over a long period of time, and they can't possibly afford to throw that out and buy a new one. So we need to look at alternatives to simply rip and replace, which we would do in a financial services environment, for example, which has a lot more money.
Yep. They can afford the latest and greatest stuff. However, still, even if they have the latest and greatest, they need to still do these basic security measures, like we said, segmentation, and we also said patching. If these are the available options at hand, these rules apply to all industries. However, in the healthcare organization settings, we have a lot of outdated systems, so we need to apply whatever we can to protect our systems, and we need to make sure that they are working. Like these compensating controls need to be working, and we need to ensure that they cannot be breached by attackers.
Thank you both. Thank you both for that. So far we have discussed, so far after all of our discussions, it makes one thing clear. Patching is not an option. Teams have to rely on compensating controls and layered defenses. That approach introduces a new challenge around visibility and volume. When everything appears risky and alerts keep piling on, it becomes difficult to decide what truly deserves attention. Richard, so are healthcare teams overwhelmed by the vulnerability volume?
Totally, yeah. And I think most healthcare entities have a hard time managing the not just the security and risks of the medical devices that we were talking about earlier, but also understanding an accurate asset inventory of what connects to their networks, right? These are not managed by hospital IT, so they don't appear in the asset management systems that are connected into Active Directory. There are a multitude of hundreds of different systems from hundreds of different vendors that are distributed across many, many departments, right the way down to lab equipment, right, that essentially provide services to diagnose patients, to monitor patients, manage patients, and treat patients. But in a healthcare environment, the patient is often the middle component between the device and the network, right? Or they are at the end of the chain on the network. So patients are at particular risk if a medical device is attacked and the drug library of an infusion pump is changed, or the output of a CT scanner is set to something dangerous, most of which you can't do anymore today, but you can certainly do that with a radiotherapy machine. And we've had instances in the past of patients that have suffered death as a result of changes to systems, software failures in systems, and other very unfortunate eventualities. I'm not trying to put the fear of God into people here, but these are risky devices that provide life-sustaining care to patients, right? If our ventilators had gone down during COVID, how many patients would have died, right? These are the questions we need to ask ourselves when we're looking at the dollars and the cents of what it costs to implement things like network access control, microsegmentation, zero trust frameworks, and some of the other leading practices that healthcare is slowly adopting here.
Thank you, Richard. And so, Jan, is there a way to avoid vulnerability fatigue?
Yes, absolutely. Last year, actually, each year, there are lots of vulnerabilities disclosed. Each year, we see 40,000 plus new vulnerabilities hit the floor, and traditional scoring gives us nearly 60% of them are labeled as critical. It's not possible for any team to follow all the vulnerabilities and patch all of them, or put mitigations before them, so they cannot be exploited. So the answer is not attacking all vulnerabilities at once. The key is avoiding vulnerability fatigue is prioritization. Traditional organizations has taken an approach trying to patch everything, but this leads to burnout and also waste of resource. So instead, we should be focusing on what is actually exploitable in our specific environment, and we need to patch those first and put a priority list and say that these ones are the critical ones for me, for my environment. So I need to fix those first and deal with the rest later. With that approach, we put translate much more security from our efforts. And in this space, validation can help us separate from the noise from the true risk, allowing security teams focus on their limited resources on vulnerabilities that can actually cause real harm. By validating the exploitability of the vulnerabilities, we can reduce the volume of issues that require immediate attention and improve the overall efficiencies of our security efforts. Assume that we have an environment with different devices, lots of medical devices, lots of security devices, or endpoint systems that our medical staff and administrative staff is using. So if we try to address all the vulnerabilities in these systems, we would be definitely overwhelmed. So the answer should be which devices are exposed to the internet, exposed to the outside. We should be start patching those first, so attackers cannot get in and get a foothold into our environment. Then deal with the rest of the stuff behind these devices, because since attackers cannot get an initial access to your system, they cannot move to other systems later. So we need to approach this with a prioritization in mind.
Yeah, Can's absolutely right. It comes down to prioritization of risk remediation, all right, based upon vulnerabilities like MDIS2 reports, CVE reports, and doing some due diligence by security teams to understand where a CVE in a Microsoft operating system may translate to a Microsoft embedded operating system that is running a medical device today, right? And it also comes down to managing all of these discrete devices more effectively than we do today, which comes down to understanding what assets we have, understanding how those assets work, what ports, what protocols, what destination IP addresses they need to communicate with, right? This becomes your NAC map, right? That you can then feed into your network operating system, or extend that out to cloud-based NAC solutions, where you can segment data, you can segment endpoints, and manage in a more effective way. I would argue that no at-risk device like a medical device should have access to the internet at all, right? That should be blocked in the perimeter firewalls, and it should certainly be blocked by internal firewalls between VLANs and any network access control framework that you've enabled in the technology that you already own. The difficulty is that most hospitals lack the expertise to enable NAC in their Cisco infrastructure, their Aruba ClearPass infrastructure, their Pan-Cortex infrastructure, because this stuff is not very simple, right? It requires a lot of thought, a lot of expertise. And that's one of the things that I've been working on with the Cylera team over the last 6 years, is building those profiles so that you can automatically, agentically almost, transport those to effective compensating security controls with a simple flick of a switch, right? And this is where we need to get to in healthcare, because we cannot hire enough smart people and retain enough smart people to secure a growing perimeter across our healthcare environments as we add more and more and more devices. That now includes things like mHealth, right, mobile health, so that we can all access our health portal via our smartphone, right? Connections that sprawl between different health agencies, population health, public health, pharmacy, insurance in the United States, and others. The growth of consumer medical devices, right? You can now upload, in certain jurisdictions, you can upload your cardiac and calorific intakes based upon what your Apple Watch and your iPhone tell you, and that can be fed into your medical record, right? And cardiologists take this information as gold, right? Whereas in fact, you could have strapped your watch to your dog and just thrown the ball around the backyard for half an hour, and the cardiologist would think you've been extremely good patient and exercising regularly, right? So these are all concerns.
Yep. As you mentioned, there are a lot of devices that use outdated software. Many of us saw that rebooting ATM machines often have Windows 7 or older systems in their embedded systems. So in the most famous case of ransomware, the WannaCry, most of the systems were infected because the embedded devices used Windows, and there was an inherent Windows vulnerability that used to exploit it for ransomware cases. It brought down NHS to its knees, and lots of medical devices and lots of healthcare organizations couldn't deliver patient care to their patients because of that vulnerability. Many of us do not think about Windows 7 running on a medical device because we think that it's a separate environment. We often see Windows in endpoint systems or servers. However, many medical devices, like most of the other devices there, use operating systems that are used in the outside, and many of them are outdated, not patched, and they are not taken care of. So they are most definitely vulnerable to some sort of attacks because they are much outdated. They are running much outdated software. So in these cases, we need to make sure that they are not being exploited, and and for that case, we need to exploit that first and know that they can be exploited or not, and we need to test beforehand so attackers cannot take advantage of it.
You raised a very good point there about Windows 7. In fact, many new medical devices that are being procured by hospitals now are running a form of Windows 10, right? Windows 10 embedded, which, as you know, is end of life as of the end of last year. So without special support. And that comes down to the fact that the development life cycle of medical devices is so long before it receives FDA approval and uses an available off-the-shelf commercial off-the-shelf packages for a lot of this stuff. I think there's another point here that we alluded to but didn't really approach, and that is one of resiliency, right? We're talking here about the impossible task of securing every device in a hospital environment, and we know that that's not feasible, not financially viable, and we would need an army of people literally running around, taking systems offline, patching them, or replacing them at great expense to hospitals. So we need to look at resiliency. What happens when the CT scanner in the emergency room goes down? Can we redirect patients to another CT scanner elsewhere in the hospital, right? And does that CT scanner happen to be the exact same model and make and same vendor? Or is it different and therefore not necessarily quite so susceptible to attack? We need to start designing in resiliency to our healthcare systems, because we have multiple single points of failure, right? And if any of you have ever been in the hospital on a Friday night and the X-ray machine goes down with all the road traffic accidents coming in, it's just chaos that ensues. I've worked many hospitals, and I can tell you that Friday nights are troublesome enough as they are. But when you get a medical device, a critical medical device that goes down, or a ransomware attack, as the NHS experienced and many others have, you're left twiddling your thumbs. You're left reverting back to physician and nursing practices that we haven't used, and nurses and doctors are not trained for since the 1970s, essentially, right? This is the challenge.
Yep, that brings us back to the segmentation and zero trust issue. We need to implement segmentation and zero trust. So even if one of our devices are brought down by a cyber attack, the others should be still operational, and attackers should not be able to take control of the entire infrastructure, entire ecosystem. So even if one device or one system is down, the other should be able to live on and deliver patient care, because we cannot stop patient care in any environment. I think we have a Q&A question.
Yeah, we do. Do you want me to read it, and you guys can maybe each take turns answering it?
Sure.
Perfect.
Yep.
Okay. So we have a question in the chat. It says, how important is it to advocate for cybersecurity training for healthcare workers? Have you found it difficult to get teams to make time for cybersecurity training, for example, to help avoid social engineering attacks? And if so, how do you make the case to leadership for teams to make time for it?
I'll chime in on that one if I may, Can. So as a former HIPAA auditor, I can tell you I've had many conversations with chief nursing officers around freeing up nursing staff to receive cybersecurity training. They receive onboard training when they come on board, which is primarily focused on privacy. And by and large, US hospitals do a pretty good job of keeping things private. But privacy is only one part of the CIA triad, the confidentiality, right? We need to look at the availability of IT systems, the integrity of health IT data, and we need to train our staff how to protect against these sorts of eventualities. The advent of phishing attacks, of deep fakes, of audio fakes, is growing by the day, right? We need much better systems to identify these sorts of advanced attacks, and we need to train our staff effectively. An annual training program for an hour just doesn't cut it, right? We have a very labor-intensive environment in healthcare. Hundreds or thousands of nurses and doctors, billing staff, janitorial staff, food preparation staff, you name it, pharmacy staff, lab staff. We need to train each and every one of them in a multimodal security education training and awareness program, SATA it's known as. And that needs to be based upon different forms of media, different forms of presentation and delivery, different forms of subtle reminders in order to remind patients about the areas that they've learned about in their training. So, for example, one hospital I've done work at has little dinosaurs inside the elevators, right, to remind doctors not to talk about patients in a public environment where they may be overheard. Other in the same hospital, they have other little dinosaurs by doors into secure areas, so that doctors and nurses are reminded they badge in and close the door behind them to prevent tailgating of people into the emergency rooms, right? The operating theater, the pharmacy, or other areas that you don't want patients to follow you in, or you don't want unauthorized staff. So training is absolutely critical. It's the single biggest bang for the buck in healthcare spend, in my humble opinion, and we should be doing a lot more about it.
Yeah, the security training also extends into our lives because scammers are everywhere, not in healthcare or in any, it's not specific to any industry. We all receive spam calls and or scammers trying to get money out of us. So we need to train our staff to the new realities of cybersecurity, because no one is immune to scam calls, phishing attacks, or other type of attacks. So in the IT people can defend against the advanced stuff like new vulnerabilities or new malware attacks. However, we need to train our regular users about phishing, about social engineering attacks. As Richard said, we need to talk about HIPAA laws and patient healthcare information. So they need to know about these type of new regulations and new realities of cybersecurity, so they can defend themselves and defend the patients' rights for the better future.
But it comes down to prioritization for cybersecurity across the healthcare environment, right? The conversations I've had with chief nursing officers and chief medical officers are: we can't take our doctors or our nurses out of circulation even for an hour with the tight schedule that we run to give them extra training, right? And I say, well, how much time overtime payments would you spend if your hospital were cyber attacked and you had to revert to paper? Right? What would the impact be from a clinical safety perspective on your patients? And how would you feel if the CEO of the hospital has to go on television to apologize to the community because a number of patients died in his hospital because they lacked cybersecurity? Right? We tend to think of things in a very different frame of mind, and I think we should stop doing that.
Training always is cost-effective way against cybersecurity attacks.
Awesome. Thank you both so much for those answers. And I'm looking at the chat right now, and there's another question. So it says, instead of relying on Windows 7 or Windows 10, it may be more advantageous for hospital systems to transition to a Linux-based operating system. Such a move could provide greater control over the environment and potentially reduce system vulnerabilities. Can you shed some light on this?
Yeah, I can answer this one.
Yeah, can go for it.
It's the ideal approach. As engineers, we always loved Linux and we always loved using Linux-based operating systems. However, it does not fit with the reality of the healthcare industry. Many applications, many medical devices still run on Windows 7, and it's not there is no alternative, Linux-based alternative that we can use for our environment. So even if we use for Linux alternatives for certain applications that are not totally replaceable with Linux alternatives. So we need to use Windows 7, Windows 10, even if they are an end of life, and it would be advantageous. However, it's not the reality.
Yeah, from a health IT application perspective, we need to we need to convince the Epics, the Cerners, the Oracles, the InterSystems, and all the other EMR and medical HIT vendors that they need to produce Linux-based clients, right? The question then becomes which flavor of Linux, which kernel versions are you going to support, and all the rest of it, right? There has been some level of support in the past to run these HIT systems, these EMR, EPR systems on a Linux or Unix-based server environment, but I don't see that coming down to the desktop. The other thing is that Linux is often a lot more expensive to develop for medical devices. We used to have most of the medical devices written in Linux until Windows became ubiquitous, or Windows Embedded became ubiquitous. And in fact, before that, we were using EEPROM, which is an even more archaic language, which I would argue is more secure than Windows systems today, purely because of its obscurity, right? You need physical connectivity to a device in order to hack it via the RS-232 port, right? Linux medical devices take about twice as long to develop as a Windows device. And most of the people that devise and design medical devices do so, using COTS components and COTS software. They go to a store, they find a camera, they find, a pump, they find some logic chips, they find a CPU, they find a motherboard that they can put all this stuff together. It's is it MIPS? Is it x86? Is it some other architecture? Most of the time, they will go for the cheapest version because they're not systems designers. They're clinicians or biomedical clinicians that are designing a clinical system for clinical use. And cybersecurity, until recently, was not even a consideration until the new FDA rules.
Great. Thank you so much for those answers to the questions in the chat. So I'm not seeing any more questions at the moment, but if you have any questions before we wrap up, please put them in the chat. Our speakers would love to answer your questions live. But just wrapping up today, it's been clear that being compliant does not automatically mean you are protected, and fixing everything is not realistic when resources are limited and environments are always on. Having tools doesn't automatically mean that they actually work. So thank you to Richard and Jan for sharing their perspectives, and thank you to everyone who joined us today. Now, once again, before we wrap up, if you have any other questions, please share them in the chat. Thank you very much.
I have one question to Richard. How long does it take to run a penetration test in an average healthcare system in US?
I think it depends on the depth of the penetration test that you're going to do. I mean, we typically start out for a HIPAA audit, for example, with a simple security vulnerability test, which includes port scans of the perimeter. It may include some vulnerability scanning of the internal connections, looking at Active Directory, for example, to see, just how many super admin accounts that you have on the device. Looking at the deprovisioning of users to make sure that everyone on the inside network has been deprovisioned when they've left, and that is becoming an increasingly challenging problem because of the way that we use temporary doctors and temporary nurses, because healthcare can't retain staff right now. We'll also look at scanning wireless networks inside of a hospital and doing an attack against the wireless networks, both hidden and unhidden SSIDs. And to be honest, most of these systems are very weak from a security perspective. Wireless particularly, because a lot of medical devices will only communicate on WEP or WPA1 protocols, and that takes about 5 or 10 minutes to hack with an injection attack, as you're probably aware. So, and it uses the same access point for that legacy medical device as is used for doctors and nurses to connect to the EMR, EPR. I was once called into a hospital to investigate an incident, which turned out to be a broadcast storm attack against wireless APs in a certain ward of the hospital. And it turned out that a dad had brought in his Android tablet for his kid to play on and had downloaded a whole load of games from various websites for his 8-year-old daughter to play on, and didn't realize that it was pinging everything in sight, mapping the networks, port scanning, and acting as a node of a command and control network. And by so doing, it was actually denying all of the cows and wows, the carts on wheels, workstations on wheels, from communicating back to the EMR. So doctors and nurses couldn't upload statistics to the system. They weren't alerted when patients needed medications. And it caused Picus cabinets to disconnect from the network, which are used to dispense drugs to patients. So these are the sorts of attacks that we deal with. Some are very easy to identify in a security vulnerability test. Others take considerably longer and require greater levels of expertise. There are some hospitals out there that are fairly well protected. They have large security teams, well funded, well resourced. There are other hospitals out there that I guarantee your home network is more secure than your local hospital, right? Rural hospitals, underfunded hospitals in particular, where your IT team may be your security team, and it's called Dave, and Dave does everything, including fix the door locks when the front door won't bolt anymore. Right. These are the sorts of resource constraints that we're facing. Healthcare in the United States faces an existential financial crisis right now. We're seeing rural hospitals close at alarming rates. Many of those are the result of cyber attacks that put them over the edge. Many are the result of reductions in Medicare and Medicaid, where a lot of rural patients are reliant upon. And for those who aren't aware, doctors are receiving the same amount or less money for dealing with a Medicare or Medicaid patient today that they were 5-10 years ago, right? Prices have remained static or decreased, and that is driving doctors away from working in those facilities to the big city hospitals. And we could be in the situation very shortly, as the Rural Health Association are saying, of a patient having to drive 400 miles to get to the emergency room, because there's nothing closer available to them. So cybersecurity is just one of many existential crises that are hitting US healthcare right now.
Yep, there are lots of diminishing budgets for medical staff, and also it reflects to the cybersecurity spending. There, they cannot afford the new staff or trained employees. They can deal with the newest and latest attacks against healthcare organizations. Like you said, there in many cases there are handful of people. They are trying to do every technical detail. They are trying to do the IT job. They're trying to do the cybersecurity stuff in the hospitals. It's not an easy task for them to deal with. I think we have a new question.
Oh yeah, I just saw the new question in the chat. So it says, although cybersecurity is not a priority in many hospitals, how can you guys address this challenge to make hospitals or the healthcare industry see cybersecurity or information security as a priority to keep their information safe?
So, I mean, there are a number of ways that hospitals can be mandated to improve cybersecurity. Regulation was the initial push. And HIPAA is through its updates of high-tech and Omnibus and other, or the proposed latest edition, which I don't even know went through last year, it was supposed to, from the FDA, is gradually tightening things up. I would argue that HIPAA at this point is no longer effective, and we need to look at a replacement, right? The HISA Act, which is the Infrastructure Security Act that has been proposed, so it's a bill rather than an act, has not made it through Congress yet, despite several attempts. But I think that would add things like resiliency to cybersecurity that we don't see right now. And we see in other jurisdictions that there are real penalties to failure to adhere to GDPR, including billion-dollar fines, right, as Google has experienced and many other large corporations. And this too, right, which has jail time for perpetrators that don't follow the rules. Fines can simply be written off on the financial ledger of a hospital. So is that really an incentive to a CEO who's planning to retire or move on next year? There's a lot of CEOs that adopt a very different approach to protecting patients, but there are some that are financially motivated and don't understand cybersecurity. So we have an education process there. We need to adopt a more risk-based approach, I believe, and we need to emphasize responsibility to communities for those who are responsible for making the budget available and prioritizing cybersecurity in a healthcare environment.
And also, these challenges, since there are lots of digital devices in our life, we are much more reliant on computers, smartphones, and other technological devices. So does the healthcare industry. They are dealing with lots of new equipment in their environments. They are much more interconnected. So this reflects to the business side of things. So many healthcare CEOs might not think about cybersecurity 10 years ago. Now it's a big business item for them to consider in terms of budget, in terms of reputation, in terms of compliance. So they need to comply with lots of regulations. They need to think about that. They need to be compliant with these rules. Otherwise, they will be fined. Their patients will be in danger, because lots of medical data give access to different issues down the line. So as Richard says, these regulatory fines might not be discouraging to implement new security controls or spend much more on cybersecurity. However, it's not as the same as 10 years ago. Now, many of the healthcare organizations think cybersecurity as a business risk. So they need to they know that they need to address certain security issues and invest in security controls down the line to prevent these fines and deliver better patient care to their patients.
Yeah, it's not just, the management of healthcare entities. And by that, I include right the way up to ministerial level, right, for government-run healthcare systems where funds are simply just not released or made available. There have been a number of initiatives in the UK that in 2024, 2025, for example, that have yet to be funded, that are drivers of cybersecurity. There are also pending regulations in the UK that would hold liability to vendors and partners, outsourcers that suffer a breach. Most breaches against healthcare entities now are coming in via a third party. If we look at the impact that Change Healthcare had against hundreds of hospitals, right, and a third of the US population, essentially more than a third of the US population, we can see that. We can see that in Synovus attack, one pathology provider that took out two of the largest NHS trusts in South London, simply by a cyber attack by Russian ransomware against one single provider that was critical to those systems. So I think vendors have got a job in making sure their systems are secure. And we're seeing that built into medical devices since the refusal to accept rule was passed by the FDA a little while ago. We're seeing that in other systems that are moving towards cloud-based services, for example, medical device as a service, some of these types of capabilities where vendors are having to step up and ensure that their systems are secure or face, some major financial liabilities.
Thank you so much for that, Richard and Jan. I'm not seeing any other questions in the chat. So if anyone in the audience has any more last-minute questions, feel free to put them in the chat right now. And Richard and Jan, do you guys have any closing thoughts or insights you want to share with everyone before we end the session today?
Yeah, it was a great session.
I'll just end on, great session. I'll just end by saying it's not all doom and gloom, that we can fix it. It just comes down to prioritization and will, essentially. And that prioritization and will needs to be driven at every level of the organization, from the board of directors that need to understand cybersecurity, that need to instill a culture of cybersecurity across all of our hospital systems, right the way through the CEO and every level of management, down to the people that walk the floors and the people that clean the floors, right? It's all of our responsibility to ensure that patients are kept safe, and that cyber perpetrators are kept outside of our networks. But I think it also comes down to prioritization by government to ensure that healthcare entities, particularly delivery entities, have the types of resources available to defend against the types of attacks that we're seeing. Some of these are nation state level attacks against a small cottage hospital. So it's a real David and Goliath challenge here as to how does a small team of 2 or 3 people protect against, the Russian military intelligence GRU, or the North Koreans that launched WannaCry, or the Chinese People's Liberation Army, which are constantly attacking critical infrastructure across the Western world. We've entered a geopolitical, economic, and geopolitical security era that we are not prepared for today. And I see the role of government in providing first-tier response or first-tier protection against critical infrastructure assets increasing as these geopolitical tensions continue to rise. So there's a bigger picture to be had here, not just down to the CISO of a hospital to ensure that he's keeping his systems secure, or she's keeping her systems secure, and that patients are not placed at risk.
Yep, I agree with Richard. It's not doom and gloom. There's a hopeful path forward for securing our environment, securing our healthcare organizations. However, we need to adjust to the new reality. Since we are adapting much more technology into our ecosystem, we also expand our attack surface. So there are lots of entry points for attackers to do harm to our environment. Before technology, they need to be physically present there. However, now they can access to our network from miles away. So this is the new reality. However, with this new reality, we also can arm ourselves with knowledge, and we can learn about these new type of attacks, how we can prevent them, how we can defend against them, so we can deliver better patient care with technology, and we can defend our organization against these type of adversarial attacks.
Thank you. Yeah, again, thank you so much, Richard and Jan, for being here today and sharing all of your insights. I know myself and everyone online really appreciates it. And I think we're going to go ahead and end our session today. Thank you all for joining us. We had a great time with you guys today. Hopefully you guys took something great away from today's session. And remember, the session is recorded and we will send out the recording after. So if you want to look back at it or share it with a colleague, feel free to. Again, thank you so much.
Thank you.
Thank you.
Bye.